So good afternoon, everybody. It's 2 o'clock Central European time. Time to start the webinar, Education as a Social Vaccine Against COVID-19. We will be offering you this webinar from the UNESCO Chair, Global Health and Education and WHO Collaborating Center in collaboration with the Chain Network, EuroHealthNet and the Newcastle University. And we're very pleased to have 3 excellent speakers from these organizations to present about the COVID-19 from the perspective of increasing inequalities in health, where we can see that there's emerging evidence that inequalities that are taking place in our societies all over the world are being mirrored in how the COVID-19 pandemic is developing. And we will talk about this issue in the next hour. We have 3 speakers. The first is Professor Terje Andreas Eikemo, who is representing the Chain Network in Norway. Then we'll have Professor Claire Bembra from the Newcastle University in the United Kingdom. And thirdly, we have Caroline Costangs, who is the director of EuroHealthNet in Belgium. And for this webinar, it's an interactive webinar. It's being recorded. It's also recorded live on YouTube. And we will tell you about how to get to the information about the website at the end of this webinar. We will use, to make it more lively and interactive, the Q&A that you can see at the bottom of your screen. So do not hesitate to ask all the speakers your comments and your questions. And we will, after each speaker has done his talk or her talk, give the feedback of your questions and ask the speakers for their feedback. Also, we will use WooClap, which is a tool that will explain how that works. And I think we can start with the first question for Terje. Why can education be seen as a social vaccine against COVID-19? Terje, the floor is yours.
Thank you very much for your nice introduction and for inviting me to answer such an interesting question. I have to admit, I'm a little bit prepared for this first question, so my answer will be a little bit long. As noted, my name is Terje Andreas Eikemo, and I am a professor of sociology and the leader of Chain, which is a center for the research on global health inequalities based here in Norway, where I am now. So I will do my best to provide a good answer to your question. Now, if you can look at the next slide, I can, let's see if we can go on to the next slide, please. Yes, thank you so much. Now, 2 of the most important resources a child is given when it is born. So 2 of the most important resources a child is given when it is born is health and the education of its parents. And as I will show you, these 2 essential resources are strongly related to each other. So in order to provide an answer to your question, we need to know how these 2 resources are related. Now, good health is important for children, not only because it will help them live through their first years, it's also important because it will help them fulfill their potentials in their lives. And this includes taking higher education or taking education at all. Now, it is also important for countries to have highly educated populations and thereby healthy populations in their efforts to obtain sustainable societies, which will also enable them to become more robust in the fight against COVID-19. So health and education are both important for people and for countries. And all people have the same rights to education and to health. But in fact, it matters where you live. Now, if you're born in a poor country, you're less likely to obtain your educational dreams, and you're more likely to live in poorer health and to die earlier of preventable diseases than if you're born in a wealthy country. Our research has shown that every additional year of education matters for child survival, now everywhere, in rich countries as in poor countries. So looking at the bigger picture, education can therefore be seen as a social vaccine against fatal outcomes of preventable conditions. Now, we know that COVID-related deaths are also preventable. Of course, only the future can tell us the degree to which education and other forms of social status will protect against COVID-related illness and death. But I would argue that education, in principle, is a social vaccine against all preventable conditions. And it is a social vaccine for people, for social groups, and for countries. And I will illustrate this point a little bit further in the next slide. Now, imagine that you are born in a poor neighborhood by parents without any education. The risk of dying before the age of 5 would be higher for you than for others born in more educated families and neighborhoods, regardless if you live in a poor country or in a rich country. Now, this is what inequality means. Inequality has no borders. It kills in all countries. So educational inequalities in health, they exist for all preventable conditions, as noted, and all preventable causes of death that we're aware of. And they are therefore the biggest public health challenge that the world is facing today. Now, no country in the world has been able to protect their populations from the negative health consequences of educational poverty. These bars, they present child mortality in world regions from 1985 till 2000. They show that children born by mothers with high education live longer than those born by mothers with less education. So what does this mean? It means that education matters. It means that the roots of health inequalities are placed in the social environments where children are born, where they grow and live, and eventually where they work and age. So more education means better access to vaccination, to clean water, sanitation, nutrition, housing, healthcare, social networks, money, social security, and we can go on. And all of these are protective mechanisms against illness and preventable mortality. So unequal access to these resources by the level of education is key to explain the global health gap. And I would think and expect that this would also matter for COVID. Of course, the future will tell us this. Now, almost 20 years later, now you can see there are graphs that have appeared on the right-hand side. These are estimates from 2001 till 2017. And as you can see, the bars are shorter, meaning that child mortality has been reduced, actually has been cut in half. But what can you see? What has not changed? Well, the pattern has not changed. Education still matters to explain health inequalities. So we need to address COVID by addressing social and educational inequalities. And the presence of such inequalities is among the biggest public health challenges that the world is facing today, because it leads to large variations in child mortality in the world. Now, this was the situation in 2017. The dark blue countries have the lowest child mortality from all causes, and the red countries and yellow countries have the highest mortality. And as you can see, there are large variations between the regions. Children do not live equally long in the world. And there's no acceptable reason why there should be differences, and why children should die at higher amounts than in other regions. And apparently the differences between the global north and the global south is quite visible. Now, the next slide shows what we are trying to do about this. Now, the fact that inequality kills at such large scale has made Shane take upon a global responsibility to monitor, to measure educational inequalities in the world. And we are explaining the causes of education on health in the world. And we are identifying policies and interventions that can reduce social and economic and educational inequalities in health and mortality. And we are not overlooking any region or country in this effort. So today, Chain is the first and only center of its kind. It's unique, we think. We think we are unique, of course, because we bring together universities, practitioners, international organizations, think tanks, the civil sector, the UN system, all together in the same organizational body with a common mission to reduce the global health gap. And in the next slide, you can see a little bit of the approach that we are taking. As you can see that the three pillars that we have, we want to explain, we want to monitor, we want to explain, and we are attempting to reduce health inequalities. We're looking at geographical regions, the life course, and we're looking at combinations of social disadvantage, which is what intersectionality refers to. So, but this is not enough. This is work we do with UNICEF, WHO, and the Global Burden of Disease Study, but measuring is not enough. We also need to explain, and we also need to change policies that can reduce inequalities. And this is why we are constantly reaching out to policymakers, European Commission, and governments. And this is why organizations such as EuroHealthNet, which is presenting later on in this webinar, and UNICEF are key partners of Chain. But even if our research and advocacy leads to change policies, that is also not enough. There are millions of people who are suffering every day, and they do not have time to wait for changed policies. They need help now, where they are now. And I would particularly mention the refugee crisis. And this task has suddenly become more urgent with COVID-19, as we know that the pandemic is hitting societies unequally, as Claire Bamberg will speak more about later. On the next slide, I'm often asked what, one more click, I'm also asked what Chain really means. It refers to the problem and to the solution. So the problem is to be chained. It is about being born into disadvantage. So if you're born poor, it decreases your chances of living, of working and aging under poor social conditions. So these are chains that need to be broken. And we have developed tools for that, as we are explaining the causal chains, and because we have a chain of research, policy, and practice partners who are with us in this fight for social justice. And if we succeed in our efforts, this would be the result. And it would be the next step on the way to ensure that eventually all children in the world would live long enough to celebrate their 5th birthday. I would now like to thank you for your attention. And please do follow us on Twitter and Facebook and help us in our fight to reduce the unfair social inequalities in health and mortality that we see. And I look forward to the discussion afterwards and to answer questions that might have come already. Thank you so much.
Thank you very much, Terje, for your excellent and to the point introduction on the issue, and stressing how much it matters where you live and where you are born. I'm sure that the work that you do is extremely valuable, and thank you for the explanation of how to break the chain. And it's great that it's reflected in the name of your network. And we encourage everyone who is participating to use the Q&A function, which is on the bottom of your screen, to let us know your comments and questions that we can share with Terge. Also, we will use WooClap, which is a tool, and we will show a slide how to use that tool, where we also ask to some questions, and we'll get the slide of the WooClap with the introduction. You can reach it on your mobile device or on your laptop, and you can use the QR for doing that. And we have the first question here on WooClap that you can, and you can also see it in the chat link, the link to the WooClap. The question is, how do you, as participant of this webinar, rate the medical impact of COVID-19 on people's health? And how do you rate the impact of COVID-19 on inequalities in our societies? These questions will stay open during the whole webinar, and at the end of this webinar, we'll share the outcome of these questions to our panelists. Sylvia, do you have any questions for Terge's first presentation?
I do not have any questions yet.
You do not have any questions yet? Okay, that's good. Then we'll continue with the second speaker, which is Professor Claire Bambra from the Newcastle University. Claire, the floor is yours.
Hi, good afternoon, everybody. Could I have my slides showing, please? Sorry, all I can see is a post-attendee Zoom meeting thing.
There we are. Yep.
Okay.
Can we get them full screen, Sylvia?
Yes, it's very small.
It's live. It's a live event, so things like that can happen.
Is it better now?
Yes,
No.
excellent.
Okay.
Thank you. Okay, so I'll start again. Good afternoon, everybody. I'm Claire Bamber. I'm Professor of Public Health at Newcastle University, and I'm also a Senior Investigator in CHAIN, the Centre for Global Health Inequalities Research that Terry has just talked about and outlined our aims and objectives. And recently through CHAIN, we've involved in thinking about the interaction of COVID-19 and health inequalities, and I'm going to give a short presentation talking about how the COVID-19 pandemic has been an unequal pandemic. Next slide, please. Next slide, please. So I'm going to start off by sharing some international data about some of the emerging evidence of social and economic and ethnic inequalities in COVID-19. I'm then going to talk about how I think we can understand this in terms of the concept of a syndemic pandemic. I'll then talk through some of the pathways where we think we are getting these inequalities, where they've arisen from in terms of inequalities in COVID-19. And then I'll draw some conclusions towards the end. Next slide, please. So I'll start here with outlining some of the data. And here on the left-hand side, you can see data. This is from the United States from April this year, when the United States had a very quick and quite deep first wave of the pandemic. And this is analysis by Nancy Krieger from University of Harvard, where she has plotted the percentage of people living in a county in the United States in terms of the percentage of people living in poverty. So we can see here, less than 5% of people in a county live in poverty, so that's below the federal poverty line, compared to up here, you've got over 20% of the population in that county living in poverty. And here on the y-axis is the COVID-19 death rate per 100,000. And what you can see is that in the areas that are have the lowest poverty rate, so the richest areas, then the mortality rate in April was around 10 per 100,000. In contrast, in neighbourhoods where you've got over 20% people living in poverty, many of which these neighbourhoods are also very much mixed ethnic background, then the rate is almost double at over 19 deaths per 100,000. On the right-hand side, this bar chart is showing similar data from the United Kingdom, and this is plotting neighbourhoods, so smaller level geography, around 3,000 households, and it's comparing the relative rates in terms of the least deprived to the most affluent neighbourhoods compared to the least affluent to the poorest neighbourhoods. And we can see here again a relative risk of over 100 in the bottom 30% of neighbourhoods in the United Kingdom. So again, similar to the US data, we can see here for the first wave that the rates were around double in the most deprived communities. And just by way of example from the United Kingdom, here's some data from Scotland, which is showing that in what we're calling the first wave in the United Kingdom, which runs from March through to July 2020, then the COVID-19 death rate per 100,000 was 86 in the most deprived 20% of neighbourhoods, compared to 38 per 100,000 in the least deprived. Next slide, please. So we can see there just examples from the United States and United Kingdom about neighbourhood level inequalities in terms of people's deprivation. Some of our data also shows inequalities at an individual level, looking here in these bar charts at occupational status. So for both men and women, again, this is data from early in the pandemic, we can see that people in more elementary occupations, working in factories, and also in kind of caring and retail and leisure services have much higher mortality rates from COVID-19 than people who are office workers and professionals. The kind of gradient is slightly steeper amongst men than amongst women, and we can also see here significant difference in mortality rates between women and men across all of the different occupational groups. So there's area level inequalities based on measures of deprivation. There's an individual level economic inequalities based in terms of people's occupational background. Next slide, please. And this is also, again, data, in this case from England, showing inequalities, and a big, important and high profile inequality within the United Kingdom that COVID-19 has drawn attention to is inequalities in terms of Black and minority ethnic groups. And this data here on the top is for the diagnosis rate, so confirmed cases amongst different ethnic groups. And on the bottom here is the mortality rates. And what you can see is that for Black British men and women, their diagnosis rate is almost 3 times as high as for white British. And if we look across at the mortality rates from this early wave, then you can also see much higher rates, particularly amongst Black British men compared to white British counterparts. So there's evidence already from the first wave of the pandemic of geographical inequalities, occupational inequalities, and ethnic inequalities. And of course, these intersect in terms of people for Black and minority ethnic groups, for example, are more likely to work in particularly vulnerable occupations and are more likely to live in more deprived neighbourhoods. So there's an intersectional element to some of these inequalities as well. Next slide, please. So as part of some work that I did as part of CHAIN, I wanted to explore theoretically what some of these pathways might be. Why are we having these inequalities in COVID-19? As Terrier pointed out in his presentation, we know a lot about health inequalities from an educational perspective when looking at chronic disease, but we've also found similar patterns now in infectious disease in high-income countries. So I draw on some work by Meryl Singer. Now, Meryl Singer was an anthropologist and clinician who wrote this idea of a syndemic, talking about his research that he did in the 1990s in urban areas of the United States. He was examining the epidemics of HIV, substance misuse and violence. And he argued to the medical profession in the United States that instead of treating them as separate epidemics, we deal with HIV on the one hand and then we'll deal with substance use on the other. He said that you need to think about them as interacting and mutually enforcing. And they came up with the idea of a syndemic. So rather than thinking of just one epidemic, you need to think about how they interact with one another. And I think this provides a useful frame for us when we think about how inequalities in COVID-19 have emerged. It's emerged because it's a syndemic of inequalities in the social determinants of health, represented by this diagram on the right-hand side. A syndemic of inequalities in the social determinants of health have then collided with COVID-19. So we get inequalities pre-existing the pandemic, for example, in housing, or education, or work environment, have then interacted with COVID-19 and led to inequalities in COVID-19. And in turn, we then need to think about how COVID-19 itself might go back and exacerbate those structural inequalities, for example, through the emerging economic crisis in Europe, and how that will impact on health inequalities into the future. So the syndemic pandemic is a way of thinking about health inequalities and COVID-19 inequalities and how they intersect. Next slide, please. And so we can think about using this concept of the syndemic pandemic and drawing on our wider knowledge as in the public health community about the social determinants of health, and think about at least 4 pathways through which we've ended up with these inequalities in COVID-19. The first one is around groups, people from more deprived communities having an increased vulnerability to COVID-19, to adverse effects. So we know there are certain clinical risk factors such as diabetes or COPD, cardiovascular disease. And if someone has that, then they're more likely to have a severe case of COVID-19 and more likely to require hospitalization. And this is more likely in deprived communities because they already have a higher burden of disease from non-communicable diseases, from these clinical risk factors. And of course, that relates to the social determinants of health outlined here on the right-hand side, and people's unequal exposure to conditions such as unemployment or poor housing, and how that's increased their chronic disease, which in turn then interacts to exacerbate their COVID-19 outcomes. So that's the first pathway. The second pathway is around increased susceptibility. And this is looking at how people's immune systems, how strong they are and how able they are to withstand and fight off an infectious disease. And some of the explanations of why there might be inequalities in COVID-19 between men and women talk about differences in men's immune responses. And I think there's an argument that can be made that different immune responses can be happening in different groups, because groups that have been more exposed over their life course, because we are largely talking about older groups that are experiencing adverse outcomes, they have a lower immune response because it's been weakened, for example, through exposure to high levels of chronic stress and raised cortisol levels. We won't go into too much more detail, but I'm happy to discuss it more in the questions, but it draws on the psychosocial theory of health, as outlined by Michael Marmot and Richard Wilkinson. So there's increased vulnerability, increased susceptibility. And the third pathway is around increased exposure. And one of the key things here is when we look at working conditions. So for example, if we think about the lockdowns that happened across a lot of Europe in the early part of this year, then many people, professionals, etc., were encouraged and able to continue working from home. But key workers and many staff who working in factories, in food production and so forth, had to continue going into the office, going into their workplaces, using public transport often. So clearly their exposure to the virus is much higher than people who are able to socially distance within the home. There's also issues, for example, around whether people are able to self-isolate. And this in turn relates to different social protection systems across Europe, which I suspect Caroline will mention in her talk later. The fourth pathway is around increased transmission. So this relates to inequalities in housing conditions and in the neighbourhood. So for example, if you live in a small house, perhaps it's overcrowded, you have less rooms than you might need. Then if one member of the family is tested positive, has a positive case of COVID-19, then it's much harder to protect the rest of the family. And this has been particularly important in the British context in terms of Black and ethnic minority groups, because often they're living in more overcrowded urban environments, but they also have multi-generational households. So if a younger member of the family who's going out to work comes home with COVID-19, it can very quickly infect older members of the family with very severe consequences. So we think that the pathways to inequality are at least fourfold. And they draw on people's different experiences in the past of the social determinants, but also currently their exposure to social determinants during the pandemic. Final slide, please. So that was just a short overview of the work we've been doing in Chain on this topic. And so to conclude, I think we can think about health inequalities before COVID have ended up resulting in an unequal pandemic. We know the outcomes are worse in less advantaged groups and communities, and we can see this across data from a number of countries. We've argued that this needs to be understood as a syndemic, the combination interaction of non-communicable diseases, social inequality, and the social determinants of health. And in order to protect ourselves and vulnerable communities into the future, we need to take more long-term action on reducing inequalities in these clinical risk factors. And if you want to read more, then the Chain publication is listed here. And you may also have seen that we have an infographic launched today that provides a user-friendly overview of this work. So thank you very much for your attention, and thank you to Teria and UNESCO for the opportunity to speak to you today.
Thank you so much, Claire, for your excellent presentation and summary of all the work that you've been doing, which is just basically re-emphasizing the importance of how inequalities lead to an unfair balance of distribution of illnesses and burden of disease, etc., and how everything is interlinked. We have a website, and we'll say that at the end of the webinar, where all this article and the other documents that our speakers are referring to, including their presentations and a summary of their presentation here during the webinar, will be shown. And I would like to, because we had a question from the audience, Sylvia, can you summarize that? And I think Claire would be the person to answer to that. Sylvia?
Yes, thank you. Yes, there's a question. If there has been enough debate at national level around the world about the balance of the risks of illness and death from COVID-19 and the risk of other illnesses and death from the impact of the lockdown.
Claire?
Yes, I mean, I think there's certainly been debate, because there was the Barrington Declaration, wasn't there, suggesting that lockdowns and social distancing should be abandoned because it was bad for the economy and therefore bad for public health. And I always think it's interesting, personally, when people who are very libertarian are interested in health and unemployment, because it's certainly an area of research that myself and Tara have been involved in for over a decade. And I have to admit, it's the first time that people on the right of the political spectrum have been remotely interested in that argument. Personally, I don't think we have to try and choose between this kind of health and wealth debate. I think in a longer version of my talk, I do talk about the economic crisis and the impact that could have on health. And we do know from research around the global financial crisis that if you respond with austerity, that increases health inequalities. If you respond with expanded social protection, then you can prevent health inequalities rising. So we do have a choice here. And I think a lot of governments have been bringing in higher levels of social protection during COVID-19, furloughing workers, for example, paying workers when their company's unable to work. So I think we have a political choice as to whether, you know, the economic crisis needs to necessarily lead to another health crisis. And depending on where you sit in Europe, you may be more or less optimistic as to whether that would work or not.
I just wonder, Claire, during your answer, how many times are you in contact with your national government?
Well, I'm not sure they're necessarily always interested in listening to someone like myself, but we did publish a couple of reports here in the United Kingdom looking at some of the inequalities in health, and that did receive quite a lot of press attention and comment from members of our parliament. So I think the health inequalities aspect is quite high on the agenda. But I say that, you know, relative to how it has been over the past 10 years, and obviously relative to other rather pressing issues you might be aware of that we have over the weekend here in Brexit land.
Yes, we know. Okay, thank you. We also have the results of the first WOOC question, and maybe Sylvia, you can show them, and maybe Claire, you can reflect on the answers. The questions were, how do you rate the medical impact of COVID-19 on people's health? And here we can see a score of 3.8 on a scale of 1 to 5, from no to high influence. And the second question, people scored, how do you rate the impact of COVID-19 on inequalities in our societies, on 4.5 out of a scale of 5. Claire?
Okay, so I think it's interesting that people have rated the impact on inequalities as higher than the impact overall, and I think that I would certainly agree that that's the case from the data we have so far. It's definitely a pandemic that's affecting some groups far more than others. Certainly we've all been affected by the pandemic, people's lives have changed radically, but I think for some of us, talking personally as a member of the professional classes, it's been an inconvenience, right? But it has not been so far a devastating impact on my family or on my employment and income. So I think we do need to bear that in mind, that those of us in very privileged positions, the pandemic has been very different from us than it has been for many of the communities near us. Yeah. So I'm glad that the audience are able to see that as well.
Thank you. Thank you. Thank you very much, Claire. And we now go to the third speaker, which will be more the answer to all these points, and how can we, how do policy reflect on that? How can we translate it into policy, all these issues? And who else could do that better than Caroline Costangs, who's director of EuroHealthNet, who will answer the question, how can the social vaccine be implemented in public policies? Also, before you start, Caroline will also show the second question of the WOOC that people can also complete that question. Sylvia, can you show that? Yeah. The second question is, on your WOOC tool, describe in keywords what you think could best protect our populations against the negative consequences of COVID-19. We show the outcome of that question at the end after Caroline's presentation. So, Caroline, how can the social vaccine, what do you think can be implemented in public policies?
Yes, thanks a lot, Goof, and I'm delighted to be part of this webinar. And I think that Terje and Claire has set out really well how inequalities and education and COVID-19 are all interrelated and interlinked, and that we need a better response, not purely a biomedical response, but very much a psychosocial response to these crises. And that's why I liked the title of using a social vaccine, because that's indeed what we need. I will talk a little bit about how we can deliver this social vaccine, and then look in the cases of the European Union to see what instruments can be helpful to realize that, and also what budgets may be available to help this making a reality. Maybe a few words about EuroHealthNet. It's a partnership of national health institutes and regional authorities, and we all work together to tackle health inequalities for more than 2 decades now. And we are based in Brussels, where we very much monitor EU policymaking and try to influence it and advocate for health equity approaches. A social vaccine is very much needed. Next slide, please. Because we are facing quite a large social sector investment gap. The European Commission has calculated that this investment gap is about 192 billion per year. And this means that there's under investments in education, in housing, in health, and in social services. So it is very large. And data also tells us that even in 2018, let's say 10 years after the financial crisis, the public sector investment was still 20% lower than it was before 2008, that crisis. While we also know that in the last decades, the demand has been increasing due to a higher number of people with chronic diseases and the aging of our society. So, and next to this investment gap that there is, we are potentially facing an economic recession due to COVID-19. The green line were the projections of our economic development, but now with COVID-19, we do not know whether we will be able to bounce back to that green line, or whether we will face this recession and how big the recession is going to be. What is important is that we do not want to go back to the austerity measures as with the financial crisis in 2008. what Claire also just said, we need to invest in social protection systems, because in the end, that lead to less inequalities. And it is the Finnish, next slide, please. The Finnish who have come up with an interesting concept called the economy of well-being. And in a well-being economy, they say that citizens' well-being drive economic prosperity, stability, and resilience, and the other way around. So the economy and citizens' well-being are two sides of the same coin. The economy well-being approach says that people and well-being needs to be at the center of the policy making, and in only that way we are able to achieve the Sustainable Development Goals. Next to the economy of well-being model, I think it's also interesting to highlight Kate Rayworth's model of the donut economy, which I'm sure you are aware of, because that highlights very much the ecological ceiling that we also need to take into account to make sure that our economy remains within the planetary boundaries that we have, next to a solid social foundation. Yes, next slide. Is this a fantasy, or can we make this into reality? Well, if you look at the European Union, well-being is part of the treaty. It's in one of the first articles. And a few years ago, in 2017, the heads of states agreed to a European pillar of social rights. And this pillar sets out 20 rights and principles for all European citizens. And the Commission is now also developing an action plan that will be presented next year during the Portuguese presidency. And this pillar sets out that everyone has rights to education, training, lifelong learning, childcare and childhood education, work-life balance, a whole set that are all important and that all can comprise a social vaccine that we just talked about. Next slide, please. Education and training is another crucial part of such social vaccine. And actually today, the European Commission is having a summit on the European education area. Unfortunately, health is not part of it. So this demonstrates the role that we have in terms of advocacy to make sure that health and health equity is seen as part of the policy design of these kind of instruments. But the European education area does talk about decreasing inequalities in education and supporting well-being at school, and also talks about their ambition to set up a quality framework for early childhood education and care. The Digital Education Action Plan, important new initiative also. Health, again, is not there, but we all know how COVID-19 has accelerated digitization and digital approaches. And we also know how many people are not able to catch up and use digital tools, and with the potential to widen inequalities. So the EU Skills Agenda is another package presented by the Commission only a few weeks ago, and that demonstrates the importance to invest in upskilling and reskilling of people that are facing these transitions, the digital transition, but also the green transition, because people will lose their jobs. And they need to be supported with employability and ways into new employment. So these sets are really crucial to, as part of the social vaccine, to engage with and to be on board. And EuroHealthNet aims to work on these further next year. Next slide, please. Yes. We all know how crucial it is to support children in their early years. They are very vulnerable. There are too many children in Europe are still living in poverty, are facing disadvantage, are facing abuse and other problems, and they need to be helped. And I'm therefore very happy with the Commission's initiative for an EU child guarantee. Also being developed for next year's publication, and the child guarantee states that every child, in particular children that are disadvantaged, are guaranteed a free education, early childhood education and care, healthcare, nutrition, quality nutrition, and housing. Also, housing is very important, as we've seen during COVID-19 amid the lockdown, how housing quality is so crucial for health inequality. So the child guarantee is another set of measures where we as public health people ought to be there on board and help shaping the actions in order to implement the child guarantee. Next slide. Yes, so how is this all going to be paid for? Actually, also today in Brussels, around the corner, all the heads of states are gathering to have their meeting on Corona, on other things, but also on the MFF, which is the multi-annual financial framework, so the long-term EU budget. And the European Social Fund is also being discussed today. That is, the European Social Fund is actually the most important fund to implement the social pillar. And it is highlighting the need to invest in people that are suffering from social exclusion, extreme poverty, child poverty, and young people that are not in employment or in education or training. The Regional Development Fund, large fund also with one priority on quality employment, education, equal access to healthcare and so on. And the good thing I hope for the coming period is that it will be more targeted to the local needs. So there will be more discussion with people on the ground to see what is needed, as we know that community work is crucial. The EU for Health program, 5 billion. You may think this is very small amount, but actually it's already 10 times bigger than it was in the previous period. Then it was only 400 million. The council will discuss the exact figure next Monday, so hopefully it will be it will stay on 5.1 billion. But the health program does not really add much to the social side, I would say, but very much strengthen the health approaches. Recovery and Resilience Facility, that is a new super large funding facility, also including loans for member states to build back their economies, to invest in jobs, in skills. And there is where we need to advocate for the economy of well-being approach that we would like to see. Countries are at the moment developing their plans how they want to spend these monies for their recovery. Next slide. Yes, just very briefly to explain to you how European monies can be used to work together on tackling health inequalities. For example, the Joint Action Health Equity Europe, JAHE, received money from the health program. And it is a group of countries, 24 countries, led by Italy, by the National Public Health Institute, to work on various dimensions of health inequalities, like the monitoring, like the ensuring healthy living environments, and so on. But really focusing on actions, on implementation and action. So a large set of actions are being taken forward by different countries. And just to give an example of three related to education, one is in the Netherlands, where they are developing a method to calculate trends in health inequalities with educational level as an indicator for SES, for socioeconomic status. In Cyprus, they want to reduce inequalities among children in different provinces through kindergarten approaches. And in Sweden, they want to reduce uptake of the differences in uptake of vaccination and reduce inequities in this way. But much more is happening in the JAHE, and please, if you are interested, do let me know and I can give you more information. Then my last slide, maybe just to sum up briefly. Yes, so a social vaccine is what we need. But it needs to be a systemic one and sustainable, because we want to see sustainable investments in this, and a well-being economy or a concept like that at the core of recovery is what we should go for. This means not only biomedical, but also psychosocial approaches. And I really would like to, I would like to thank Claire, because the syndemic pandemic is really a very nice way to visualize this and to claim the psychosocial side of things. The long-term approach is very important, not only reacting to what's happening now, but what will happen in the future. Public health leadership in order to work with others across sectors, to also use the funds that are available and use the opportunities that are out there. And I gave a few examples in my presentation. And we have to work better together, share our examples and ideas from local up to the global levels. And I did not even have time to talk about WHO, because WHO also has a range of initiatives that are useful for us when we talk about a social vaccine. So Health is very happy to be part of CHAIN. I think CHAIN offers such platform to exchange ideas, and particularly to work on the evidence, because we need the evidence to feed that to policymakers. And also our partnership with the UNESCO chair on health and education is also very much valued, because that allows us to exchange more at the global level. So thank you for being here, and thank you for listening.
Thank you very much, Caroline Costangs from EuroHealthNet. Excellent introduction and a plethora of actions and policies on the EU level, which maybe are also relevant for other parts in the world where governments are trying to find an answer to these. And it's amazing how inequality seems to be much more on the agenda as it used to be. And hopefully our researchers can see the impact of all these policy measures in the future, that there actually will be a reduction in inequalities in health. I would like to check with my colleague Sylvia if there's been any comments or questions coming in on the Q&A and chat for Caroline. Sylvia, can you?
Yes, thank you. We have 2 questions for Caroline. One in the chat. I'll read it. It's long. Assuming the link between adult education and child mortality is partly linked to higher skills and partly to higher material means, amongst other factors, is it possible to understand the relative influence of each aspect? And especially since it is predicted that we will see a mass disappearance of mid-level jobs, how can we expect this to change the correlations? And how can public health community harness this new wider recognition of the links between housing and employment to make progress on policies regarding social determinants of health? What actions should people take now?
Caroline, what would you?
Well, I would say it's a very long question and a bit complicated, but I would say that to understand the relative influence of the different factors, whether it is income, whether it is employment, whether it is, I think that is more for our researchers, to be honest. So I'm looking at Claire and Terje. To what extent are you able in the research to really see, okay, what are the relative influences from these different factors? And so...
Okay, Claire, would you like to comment, please?
I think it says in the chat that this part of the question is for Terje.
Yes, I can... I think the short answer is that if you just, you cannot inject education in someone, like you would inject a normal vaccine and then you would obtain, let's say, better health or, be better protected. It's all about what education enables, but it's also about the skills you have already to obtain education. So all of this is intertwined. I think that's the closest I can get to a good answer in a very short time. I would like to point out a few of the things that I've catched up also during this discussion, also relating to some of the questions that have been already asked. I think a key question is, what is most dangerous? Let's say, is it the consequences now? No, is it important to act now and to prevent deaths and illness related to COVID, or should we be more afraid of the long-term consequences of the actions that we have to take now? Regardless of the answer, regardless of this answer, we have to focus on the double burden, because regardless of what is most dangerous, what is happening now is a burden for those, a higher burden for those with lower education. What will happen will also be a higher burden for those with lower education. So this will not change. Perhaps we don't know yet if people will die now or in the future. We will see both, but in both periods, now and later, it will be the burden of the poor and the less educated. So I would like to highlight this double burden of COVID-19 already now. Now, the second thing I would like to highlight is the vaccination, because that's the real vaccination, the real injection. So what we see when new technologies become available for us, when innovations appear, what happens is that the higher educated get access to these first. And only when there is full coverage, when it's free, when it's accessible, it becomes available to all. So I'm just afraid, I know that we are focusing so much on providing the vaccine to risk groups. But what we always see when a new technology becomes available, I hope this will be an exception from this rule, is that it becomes available to those with most resources, to those with highest income, those with most knowledge, those with let's say, with higher prestige jobs and positions. So, so this is just a warning. I hope that this can be counteracted already now. And my last point is that education is a fundamental resource regardless of time and space. So education has played a role in the distribution of health 100 years ago, and it will still be important 100 years from now. It might be a different disease, a different pandemic, hopefully not, different conditions, but it will always determine the stratification. So it is a fundamental resource. Education does magic to societies, to people, and we have to promote education as much as we can. But I would just like to say that, we have to look at education as both as what it enables and what it protects us against. And I think that just the sum of these three presentations that we have had today have been highlighting these things from different perspectives.
Thank you very much, Terje. And I would like to get to the results of the WooClap question, because we asked our attendants to this webinar what keywords they would choose to best protect our populations against the negative consequences of COVID-19. And maybe it's good when you read this. Oh, Sylvia, it's gone. We just had it. Yes, thank you. We have the results here. And maybe we ask each of our panelists to give a short response on that. First, Claire, would you like to reflect on this and also on the webinar? Just a comment, please. Claire?
Certainly, I think we've emphasised how it's an interaction of a lot of the different factors that the participants have listed here on screen. I think we're particularly talking now about the role of education in terms of inequalities in COVID-19, but I think, as Caroline outlined in her presentation, we need to think about social support into the future. And as I mentioned in mine, obviously, I think in the next few months, we're going to be talking increasingly more about the employment impacts of the pandemic and what we can do as a public health community to try and mitigate those. Yeah,
thank you. And Caroline?
Yes, I'm happy to see support indeed. I think social protection is really important to provide the safety net for people, but also social investment is what we need because we are finding ourselves in the midst of these transitions, and about digital skills, about keeping your jobs in the green transition. This and as was mentioned by Terry before, it's often the people that are higher up that are able to grab all the opportunities and look after themselves. but we need to make people resilient to these changes and therefore proactively provide support, and which is important to highlight.
Thank you. Terje?
All of these words, I read each and every one of them, makes sense to me. I would like to highlight the one which says 2008. And that reminds all of us that we should learn from the past. And we are learning from the past. The models that we are currently looking at are based on the consequences of a previous economic crisis. And that should also be a reminder that we are now living in a time which should provide evidence for the future, for the next pandemic. There is a 1% chance that every year we'll experience another pandemic. So we need to collect as much data we can now. We need to take the responsibility as researchers to collect as much data we can now to enable researchers during future pandemics to apply our data and to act perhaps even better and more informed during coming pandemics.
Yeah. Okay, thank you very much. I see that the time is up. Unfortunately, time flies when you're having fun. There are a few more questions on the Q&A, and we suggest to answer these on our website. Please be in contact with us, and we'll ask our panelists to provide an answer to this. And maybe before we close, I would like to emphasize that actually today, EuroHealthNet and Chain have published an excellent fact sheet on this particular issue. Maybe Caroline, you would like to give a few words on that? It's an advertisement, what do you call that, commercial break?
Well, I suggest all of you to have a look at it, and in particular to use our fact sheets and to take the fact sheets and to talk to the members in your national parliament or to your local politicians, because they can take it up and do something about it. And the fact sheet is based on the research from Chain and from Claire in particular. So we are very grateful for the cooperation, and I hope that it is useful to all of you. Please disseminate it.
And I think it's a great example of how you can translate research into policy and practice. And we really hope that we have more examples of this. The answer will not be given at the end of this webinar. We've had a lot of different perspectives on an extremely relevant issue and how education can be a social vaccine against COVID-19. The answer is yes. And then how to implement it is the next step. I want to thank our panelists, Terje Ekemo from Norway, from Chain, Claire Bambra from Newcastle University, and Caroline Kostangs from EuroHealthNet. And the link on the website of the UNESCO Chair will be shared with you. You can see it on UNESCO Chair at Global Health and Education. And having said that, I want to thank all of you and have a good day.